Greetings, my name is Rachel Deussom. I'm the Health Practice Director at Chemonics International. In my work, I strive to center humans, think systems, and seek justice. My WomenLift health journey towards more authentic, inclusive, strategic, and impactful leadership was dedicated to decolonizing global health through inclusive learning and intentional partnerships. The elephant in the proverbial room of global health is named power and privilege. Decolonizing global health is indeed a complex endeavor with many different parts to explore. And I respect and am grateful to all of those abolitionists who have established languages and taken the field in the direction that has needed to go so far. When we look at this elephant, patriarchy manifests. Women are the lifeblood of the COVID-19 response, but worldwide, only 25% of leaders in health are women, despite women representing 70% of the global health workforce. Too many are not adequately paid nor protected at their jobs. Racism and tribalism are public health crises in the US and around the world. What are the opportunities and challenges to increase the global health workforce's diversity, equity, and inclusion? And as a cis, white, heterosexual US-born woman, how can I take steps to eradicate manifestations of white supremacy and saviorism and lead others to do so? What is the contribution or consequence of my foreign gaze? How are past and current systems and structures for global health programming embedded in coloniality? In 2021, I led our Global Health Division's Diversity and Inclusion Working Group to facilitate an interactive learning series. We started local, exploring the underlying historical and systemic causes of health inequities in the US. We then shifted to explore the colonial history and influences in countries with global health programming to see how pervasively their structures and systems manifest today. In our second learning session, we analyzed a donor request for information, or RFI, to identify and name its demonstrations of coloniality and perpetuations of power imbalances. We continually reflected on high-level commitments from global health and development leaders to see how we aligned on their visions for DE&I and shifting power and resources locally. But for me, the highlight of the series was our blue sky visioning. What should future global health programming look like? Comparing our current reality with this vision, we use the abolition praxis to identify what needs to continue, what needs to stop, and what needs to change. I looked across the screen and through the chats during this session to see so many incredible ideas. Our division has several recent graduates, most of whom are women, and I was heartened to see how they were optimistic, creative, and innovative in how we can do things differently. We then applied design justice principles to synthesize the recommendations, specifically for how to evolve our new business processes when it comes to technical scoping, recruitment, and partnering. We're documenting experiences and lessons learned as we pilot approaches and improve upon them. My own health practice team has further operationalized DE&I principles and the learning series recommendations to support our division's current portfolio and its formidable leaders around the world, and to support our staff's professional development, notably to facilitate practical local learning opportunities that can integrate other technical sectors that might be contributing to systemic determinants of health, such as governance, education, and gender, as well as identify opportunities to foster more inclusive leaders. Through this process, we have strengthened our collective awareness for addressing asymmetries of power and privilege to positively transform global health programming within our circles of influence at the individual, team, and divisional levels, with the goal of ultimately contributing to an evolved global health industry. The learning series will be mainstreamed into our divisional orientations and updated to shape the direction forward for our staff, systems, and processes. We will be aligned with a common vision to develop and nurture respectful, meaningful partnerships in global health programming and development, where we can bring value, support risk that others may not be able to, promote innovation and inclusion, and stand in solidarity with local actors and communities, remembering that global starts with local. And by continually collaborating, learning, and documenting our approaches, we'll demonstrate our commitment to a more just, gender transformative, evolved approach to global health programming so that good health and well-being is attainable for all. I have so much gratitude to the WomenLift Health leadership team and the amazing women from the 2021 cohort. It's been an incredible journey of self-awareness, empowerment, and community. I carry your inspirational stories and wisdom with me. Keep soaring high. Thank you.